discuss in particular the PROTECT-2 trial. It was nice to see the Kaplan-Meier curves by Dr. O'Neill, but I will dissect the data into more detail. So this is my relevant or possible financial relationship, so I don't have one, but I believe in evidence and I believe in randomized trials. And that's the reason why we do the randomized trials. And usually, at least for the intra-aortic balloon pump shock 2 trial, this is what we did. We did a randomized trial, and we are not using the intra-aortic balloon pump in Germany anymore. And also I know that many other countries in Europe are doing it because they believe and they follow evidence. So I try to give you some information on mechanical circulatory support in first high-risk elective complex PCI, as Dr. O'Neill has done, and I will also briefly discuss the possible benefits in cardiogenic shock. So there are some indications based on, so this is what we did, PCI, Alate Kefo from Milano has done it. As you can see, I'm also one of the authors, and I always try to push the people to evidence because it was not so easy, because there were so many believers in that we have to use it. At least we came up that the intra-aortic balloon pump in high-risk PCI should not be used based on BESIS-1 trial, but we said, okay, so in highly selected patients undergoing high-risk PCI, there may be an indication based on PROTECT-2. But we will have to look into the evidence behind this. So this is intra-aortic balloon pump. This has already been mentioned. So we have the BESIS-1 trial. It's a randomized trial done in UK. As you can see it here, once again, severely reduced ejection fraction less than 30%. And patients were randomized to elective IVP or no IVP. And this were the main endpoints. So in hospital MACE, there was no difference. Procedural complications were significantly reduced. This was mainly hypotension, so there was less hypotension when intra-aortic balloon pump was used. Honestly, I'm a little bit surprised on this because the intra-aortic balloon pump does not change the mean arterial blood pressure because it's only shifting diastolic blood pressure to systolic blood pressure, or the other way around, but it has no effect at all on the mean arterial blood pressure. Now we have to look for the impeller, so we have just heard PROTECT-2. You have seen this study design, but I just come back to the primary study endpoint. Have you ever seen such a ridiculous 11 composited endpoint for a randomized trial? This is what we're not doing anymore in clinical practice, or it's more a decade ago. But it's combining very soft endpoint together with hard endpoints. And this is also important, so Dr. O'Neill just mentioned it, it has been stopped for futility. This is important. So this is not a randomized trial which has been finalized. So this were the primary study endpoint, major adverse events, no effect at all. There was maybe, we can consider it, there's a trend towards better outcome at 90-day follow-up. Now, this is what always is shown by the believers in the impeller. So the per protocol analysis at 90 days, which was significantly better with a p-value of 0.048, so seems to be beneficial, but you have to look into more detail into the endpoints. Look for this. Death, heart endpoints, and myocardial infarction were numerically higher with the impeller in comparison to intra-aortic balloon pump. So the difference in the endpoint was mainly driven by hypotension and repeat revascularization. So this is what we have to keep in mind. Heart endpoints were not changed by the impeller in comparison to the intra-aortic balloon pump. And this is what evidence is. So heart endpoints are death and myocardial infarction. Nevertheless, it has been approved by the FDA, and this is what you are doing in the United States. We also have, I always see it, maybe I'm a little bit too old nowadays, so the younger people, they are not able to do easy PCI, even more complex PCI without an impeller, where I always ask why you are using it. This is something I do in 5 minutes, and I don't need this device. So nevertheless, this is what you are doing in the United States. There's a huge difference in centers, as you can see it on the left-hand side. There are some centers which are using this device very, very often, and then there are centers which are not using it as often. On the right-hand side, you can see the indications. So triple vessel disease, left main disease, but only a few cases with ejection fraction of less than 30%. And this were the inclusion criteria for PROTECT 2. So you have adopted it, although there's no evidence at all, you are doing it now nearly on more and more cases. Now looking for the data. When you are comparing it, impeller versus no impeller, on the left-hand side you can see it. There's significantly more death because this is selection criteria, this is clear. So you only selected high-risk patients. There's significantly more cardiogenic shock, and there's significantly more new heart failure. And you have significantly more complications, more stroke, more tamponade, more major bleeding, 18% major bleeding if you're using active mechanical circulatory support, in this case the impeller, for high-risk PCI. And vascular complications, 2.3%. I personally believe this is probably also underreported. At least what we have seen in prospective registries, this is much higher. Now we have to look for the adjusted comparisons. For MACE, significant reduction, but once again, keep MACE in, this is not death and MI. Safety, severely more complications with this device in comparison to intra-aortic balloon pump. If you look at or dissect it into further in unprotected left main, no benefit with respect to MACE. Left main lesions more than 50%, no significant benefit, but significantly more complications. Same, or maybe a benefit with triple vessel coronary artery disease. If you use orbital or maybe normal rotablation, no benefit, but more complications, at least 2 high-risk features. There's also no benefit with respect to MACE. So this is observational data, registry data, but once again, not really confirming to the use of this device. Now, just very brief look into what we are doing in cardiogenic shock. Randomized data, impeller or tandem heart. You can see it down here. So 30-day mortality, no difference if you're using active mechanical circulatory support in comparison to nothing. There's some benefit on the mean arterial blood pressure. There's some benefit on lactate. But on the other hand, you once again have more complications, you have more bleeding, and you also have a strong trend towards more limb ischemia. And I've learned, and I know the data, bleeding and limb ischemia is increasing mortality. So on the one hand, we have some hemodynamic benefits, and on the other hand, we induce more complications. And now what we know regarding cardiogenic shock is that early revascularization in acute myocardial infarction can reduce mortality. Culprit shock, our randomized trial in Europe has shown that if we restrict PCI to the infarct-related lesion only, then we can also reduce mortality. And guidelines formally said that you have to do everything. Clearly, we could show by randomized trials that is not beneficial. Norepinephrine is probably better than any other drug with respect to vasopressors. IVB clearly has no benefit, and that's the reason why, at least in Europe, we adopt the guidelines. It's a class 3 recommendation. That's the reason we are not using it anymore. And if you are using unselectively mechanical circulatory support, you are also not able to reduce mortality based on randomized data, currently less than 200 patients randomized. So in summary, there's no evidence that heart endpoints can be reduced, as I've shown to you from PROTECT 2. For me, it's surprising that it has been adopted and that it's currently so often used in clinical practice. Maybe it's a case we have seen by Dr. Sharma. This is a case where we probably would use it. Currently, we have no subgroups. These needs to be defined. This is wrong, so this is PROTECT 4. RECOVER 4 is for cardiogenic shock. We need this trial to really can say if there is a benefit if you're using it. For cardiogenic shock, it's exactly the same. No evidence that heart endpoints can be reduced. It's also for me surprising that we have adopted it in such a often way. And subgroups, I don't know. We have to wait for the randomized trials, DANGER, ECL shock. And you can see ECMO, there are currently 3 ongoing trials. I give you the numbers. So this is what we have currently included in our ECL shock trial, 365 patients as of today. We hope to finalize the trial ECMO versus no ECMO in severe cardiogenic shock by the end of the year, and hopefully present the data next year. The EuroShock trial has been stopped because of slow enrollment, and also the Danger trial is enrolling still extremely slow, and we will have to wait if really Impeller will be able to reduce mortality for patients with cardiogenic shock. So thank you.